Good evening and welcome to Conversations Live, Colon Cancer. I'm Patty Satalia. 1 out of every 20 Americans is at risk of developing colorectal cancer, which is the second leading cause of cancer death in the United States. March is Colon Cancer Awareness Month, and tonight our experts will talk about the risks, screenings, and treatment options. We'll also take your questions. Our telephone number is 1-800-543-8242, and our email address is connect@wpsu.org. You can also join us on Twitter. Find us under the address @WPSU and use the hashtag WPSU Conversations. Now let's meet our guests. Dr. Hassan Sheikh is an assistant professor of medicine at the Penn State College of Medicine. He is a staff oncologist at the Cancer Care Partnership, a joint venture of Mount Nittany Health and Penn State Hershey Cancer Institute. Dr. Robert Koo is a colorectal surgeon for Geisinger Health System. He has vast experience with laparoscopic colon resections, endoscopic microsurgery, and reconstructive surgery of the colon. And Shireen Stanford is a producer-director here at Penn State Public Media. Shireen was diagnosed with colon cancer last year at the age of 32. She underwent surgery and 12 rounds of chemotherapy and thankfully has responded well to treatment. Thank you all so much for joining us.
Thanks, Patty.
Thank you.
The good news is that death rates from all cancers combined is continuing the decline that began in the 1990s. Dr. Sheikh, what's the status, though, for colorectal cancer?
Yeah, so colorectal cancer also remains a very important cancer, and as you mentioned, it's still the second leading cause of death. If you look at the national databases, about 150,000 patients are diagnosed with colorectal cancer each year, and about 50,000 people die from this disease each year. So it is still a significant cause of morbidity and mortality. However, I think there are some significant trends in the epidemiology going back over the last 15 to 20 years. The databases show that in people above the age of 50 years, there has been significant decline in both mortality and incidence, largely attributed to screenings. And about 30-35% decrease. So that's quite significant. So I think we have made some real good progress in that area. However, what is more disturbing to me is a quite opposite picture emerging in a young onset patient population.
15 to 39.
Correct. So there is actually a rise, about 2.1% per year, and across all age groups within less than 50 years of age. So I think there's some significant trends ongoing. We have made some progress, but still more to go.
And not just here, but worldwide, because I read that there's a 64% increase in colon cancer among that young adult population in places like Australia.
Correct. It's a global phenomenon, and certainly the statistics in the United States are quite concerning, and they point towards similar trends and increase percentages.
Let's talk, Dr. Koo, a little bit about what we know about the cause of colon cancer.
Two primary things. It can be genetic, it can run in your family, and it can be the environmental factors. And it's not the environmental factors that we commonly think about, like Agent Orange or radiation. It's the simple things like a poor diet that's high in meat and high in fat and low in vegetables. That's a big risk factor. People never think about that. Lack of exercise and obesity, these are other key factors, and maybe even smoking. But so basically it breaks down to genetics, what you are born with, what's passed along from your family tree, and what you acquire in terms of bad habits through the years.
And genetics, though, really only plays a role in 5 to 10% of all colorectal cancers.
Even so, if there is a positive family history, like if your mother or your father or brother or sister got diagnosed with colon cancer, you should go and look for screening. You should be screened, even if you have no symptoms. And that's the message we need to get out to the folks.
The recommendation is that screening begin at age 50. I want to move to Shireen, because Shireen is none of the things you just described. She wasn't a big meat eater. She's healthy. She's trim. She's not obese. Talk a little bit about what made you suspect that you had a problem.
I think one of the things that Dr. Koo was good about, Dr. Koo was actually my surgeon, and my doctor's word was just trusting my instinct. So I know my body very well, and I knew that things weren't right. I had bleeding. I was also severely anemic, and so a lot of those things together made me realize that something just wasn't right. I also had a pain in my lower left side, and I kept saying to my friends, I just know something bigger is wrong. I didn't think it was cancer, but I knew that something was wrong.
Was the resistance when you went to, I'm assuming you went to your general practitioner first to say this? So often I read that young people who present looking as healthy as you do say, well, you're probably anemic, or you're probably working hard. Were your concerns, did you get a response like that?
No, I was very lucky. I have a really great primary care physician, and of course that's not the first thing we thought. The first thing we went to was not, you should have a colonoscopy. That certainly wasn't the case. But after a while, I think we both were really not comfortable with me continuing to have the symptoms I was having, because they were intermittent. It wasn't like I wasn't feeling well or anything like that all the time, and the bleeding was only sporadic. So I actually didn't have that resistance, and I went in, saying, oh, I'm going to ask for a colonoscopy, and I'm going to demand that I have one. And before I even said that, he said, I'm going to send you for a colonoscopy and an endoscopy.
Let's talk a little bit about colonoscopy, which is regarded to be the best tool that we have in detecting early stages of cancer. But from what I'm reading, 40% of those who are recommended, anyone over 50 should have their first colonoscopy. We're not getting them. Why is that, Dr. Sheikh?
Yeah, I think there are different factors. I think the invasiveness of the procedure, sometimes people do not want to go through the procedure. There's also less awareness, I think, with regards to screening recommendations. And so I think there are patient-mediated factors which contribute to less screening, although I would say that we do have good evidence that more and more people are going towards screening. So the trend is on the rise, although it needs to be better.
Well, the one thing about colon cancer is that it need not be a fatal disease, and so with early screening, something that's precancerous can prevent you from getting cancer. So the motivation for having a colonoscopy seems to be pretty big.
Correct. Yeah, and I think we just need to emphasize this point that the earlier the detection, the better outcomes you will have. If you catch the disease earlier on, you're going to have better outcomes. If you wait till it's advanced, then unfortunately the options will be less, and your outcomes may not be as good. So definitely, I think we need to bring this point home.
Shireen, tell us a little bit about what your options were. What was your diagnosis?
So I had, Dr. Koo did my surgery, and I think we discovered I was stage 3 by that point. And so if you're stage, which means that the cancer had spread to my lymph nodes. And so at that point, they recommended that I had chemotherapy. And so that was my treatment. So I had a colon resection surgery, and then I also had chemotherapy. 12 rounds of chemotherapy.
I want to follow up on that in a moment, but what exactly does colon resection mean?
To remove a piece of your colon.
And how common is that for someone in their 30s? And are there options, depending upon it? I guess what I'm asking is there age-appropriate treatment?
All treatment for colorectal cancer involves resection if you want a cure. So there's no way to avoid removing the tumor. So no matter what age you are, you're going to have a resection at some time. And also speaking to the screening, this is not like breast cancer screening where you look for a lump. Invariably, that lump is already a cancer. What we're doing here is more important than finding the cancer is finding the pregenital lesion, which is the polyp. So if you get the polyp, you prevent the cancer, and these polyps generally show up 5 to 10 years before. Oftentimes we have people come to see us, they say, well, I've had this cancer, just diagnosed, has it just been here a few months? It really has been there for 5 to 10 years, and if you'd had a colonoscopy 5 to 10 years before, we would have found the polyp that became the cancer.
Which is problematic to me because on one hand we know that more and more young people are getting colon cancer. On the other hand, the recommendation remains wait until you're 50.
It's true. It's still a minority of folks, probably less than 5–10% that are under 50 that get the colon cancer. Her story is very unusual, but she did the right thing when she didn't ignore symptoms. You really want to get the screening recommendations have to be done on a mass population scale. We can't pay for everyone to have colonoscopy. In fact, the government can barely pay for everybody over 50 to try to have colonoscopy. I mean, their goal for the U.S. government is to aim for 80% by 2016. I don't know if we have that kind of resources to do colonoscopy screening, but there are other ways you can do screening in looking for this cancer.
In fact, there's a new at-home stool test for colorectal cancer that has not yet been approved by the FDA, but appears to be 92% effective in finding cancer, colon cancer.
Yeah, I think there are newer tests coming out, and these are mostly genomic or DNA-based tests. So I think the field is moving towards more genomics, and I think over the next years you're going to see more of these tests. What's needed right now is validation of these tests to make them standard of care. As of this point, there is no standardized genetic-based test which could be simply done on a stool sample at home. Colonoscopy still remains a gold standard, and I think still we're going to follow this for some time till the FDA approves these newer tests.
Let's talk a little bit about colonoscopy, because there is this ick factor, this scariness associated with it. But as someone who has had a colonoscopy, it really isn't a big deal. In fact, you wake up and say, did you do the procedure or not? It's really gotten to be a rather simple procedure, although not everyone, Dr. Koo, is as good at doing colonoscopies as others. What's your recommendation in terms of finding someone who really knows how to do it, not just know how to do it with less risk, but also there seems to be a measurement for whether a physician is good at detecting these precancerous polyps?
Right. In the old days, we used to just get in, get out quickly. The recommendation now is you find someone who takes their time, he or she takes their time, taking at least 8 to 10 minutes and withdrawing the scope, looking very carefully at the entire colonic mucosa. But if you're alluding to things like complication and the ability to detect adenomas or polyps or cancers, unfortunately, all those measurements are very poorly done. Like even if you go to things like health grades or these doctor websites, they're not well maintained. There are very few reviews in there. You're going to have to pretty well rely on word of mouth to get your scope done. And you need to know also that not everybody can get a colonoscopy, either because of economic situation. And we already heard about the ick factor. I remember one famous study of many years ago. They actually offered in one university town free colonoscopy to all the university employees, and very few people actually showed up for the colonoscopy.
We'll follow up on that in just a moment. But if you're just joining us, I'm Patty Satalia, and this is Conversations Live Colon Cancer on WPSU TV, WPSU FM in Central Pennsylvania, and on WQLN TV in Erie. Our guests tonight are Dr. Hassan Sheikh, a staff oncologist at the Cancer Care Partnership, a joint venture of Mount Nittany Health and Penn State Hershey Cancer Institute, Dr. Robert Koo, a colorectal surgeon for Geisinger Health System, and Shireen Stanford, who is currently in recovery after surgery and chemotherapy. Our telephone number is 1-800-543-8242, and our panelists are ready to take your phone calls. If you'd prefer to email us, our address is connect@wpsu.org. You can also join us on Twitter. Find us under the address @WPSU and use the hashtag WPSU Conversations. I wanted to talk with Shireen a little bit about, you know, at one time we were afraid to talk about breast cancer. And the incidence, the rise of colorectal cancer among young people makes it more important that we do talk about this. And so I congratulate you and thank you for your willingness to tell other people. And it reminds me of some things, you have a blog about this. And the reaction from people who read it was, Thanks for sharing this information.
Yeah, I think that people are really embarrassed to talk about things like poop. But I think it's really important, and if I was scared to talk about that, I might not have my life. So I think that that's one of the things. I have a really good, you know, I grew up with a mom who's a nurse, and so we talked about lots of things at the dinner table that maybe other people weren't comfortable with. But again, that ability and that lack of fear to talk to people about it really, I think, is the reason that we caught it even when we did. So it's really important, and I just would encourage people to not be afraid, especially to your doctor. You know, I'm comfortable with talking about it to lots of people who want to hear it, but I think, you know, doctors hear stuff like that all the time, and if you're going to be honest with anybody, you should really be honest with your doctor.
And we're talking about our lives here.
Yeah.
So talk about it. What did you want to add, Dr.
I just want to
Sheikh?
add one more point here. In young individuals, it has been noted that it takes about 6 months before they're diagnosed on average. So there's a significant delay. And there are both patient-mediated factors, just as Shireen mentioned, embarrassed about the symptoms, not appreciating the seriousness of the symptoms, and just denial of the symptoms sometimes. But however, there are also physician-mediated factors as well, such as misdiagnosis or a low index of suspicion in a young person with these symptoms. So I think there are factors on both sides, and those need to be addressed.
Now, Shireen mentioned some symptoms that she experienced, but what are common symptoms, and how likely is it that we have cancer or precancer as a young person and absolutely no symptoms?
Yeah, symptoms alone can be a little bit challenging because the symptoms across all ages are about the same. Commonly, you have abdominal pain, rectal bleeding, sometimes nausea, symptoms of obstruction. So these are, and also sometimes anemia. So these are common findings that you will find on their blood work or their physical examination. So we need a good, astute physician who will go a little farther than you know, in analyzing the situation and doing the proper workup, referrals for colonoscopy, etc.
Despite, Dr. Koo, the fact that there are more deaths related to colorectal cancer than breast cancer, there are 3 times more research dollars going to breast cancer than to colorectal cancer. And I wonder if part of that is this lack of public awareness and also this stigma, this fear about talking, as Shireen said, about poop.
Absolutely, I agree with you 100%. I think that our biggest person is Katie Couric, known as the Couric factor, ever since she made it public.
In 2000.
And then the staff of the Today Show had their colonoscopies on air. That really pushed the envelope for us. And in fact, some of the hospitals were pushed to provide more colonoscopy services as a result of that. That helped us a lot.
Amazing. When it happened, I thought, I can't believe it, but she showed that it really was a relatively simple procedure, not without risk, but something that she did on national television.
And her whole point was, really, the most common symptom is no symptom. Go get screened if you're over 50.
All right, we go now to Sandy, who's calling us from Marion Center. What's your comment or question, please, Sandy?
The question that I have is, my husband's father had what they called fistulas in his bowel area and I just wondered, what is the difference between a polyp or a fistula? What are you looking at?
Dr. Koo?
A fistula is just communication between your bowel and the skin, or a bowel and your bladder or some other organ, and it's not necessarily because of a cancer, so really no relationship necessarily.
Thank you.
Okay, thank you.
Do you have another question, Sandy?
No, I was just concerned about it because my husband kept telling me there's a difference, and I just wanted to make sure, and I thought this was a good time to find out. Indeed
it was. Thank you for your call and your question. There are 2 actually different kinds of scoping, and so maybe you could tell us, Dr. Sheikh, the difference between a colonoscopy and a sigmoidoscopy and why a person would use one over another.
Yeah. So the colonoscopy examines the entire colon, both the right side and the left side, all the way to the terminal ileum, which is where the small bowel starts to join at the point with the large bowel. So colonoscopy in that way is more extensive and has a more thorough look at the entire colon. Sigmoidoscopy, however, only looks at the distal end of the large colon, which is the area called sigmoid and the rectum. So I think colonoscopies are preferred over sigmoidoscopies. And of course, these are case-by-case basis. In some patients, sigmoidoscopy could be easier because of the convenience of the procedure. But I think that most gastroenterologists would recommend a colonoscopy, and certainly the U.S. Preventative Task Force recommends a colonoscopic examination.
And in fact, some say that is comparable to doing mammography on one breast and not the other.
Right, in some ways, yes, because you're missing some part of the colon with sigmoidoscopy, yes.
Let's talk a little bit about effective bowel preparation before a colonoscopy, because if you want good results, you need to do what the doctor orders. And maybe we can get Shireen to talk about that as well. Why is it so critical?
It's critical for visualization. My analogy is like looking at the Mona Lisa with mud on it. You won't see much. I mean, a good example is also Mehmet Oz. When he wrote about it in Time magazine a few years ago, he actually wrote that he, being an important doctor, did not follow the instructions and did not take the bowel prep and had to have his procedure canceled and
done a
repeat
second
it.
time.
So don't make his mistake.
Any comments, Shireen?
Well, I would say that in the case of the colonoscopy and the case of the actual surgery that I had, you know, as a patient, you really feel sort of helpless, and there's not a lot that you have control over. You're putting, you know, yourself in the hands of other people. So about the only thing that I had control of was making sure that I followed the directions so that they could do what they needed to do to figure out what was wrong. And so for me, it was actually sort of like empowering. I just thought, well, I have one part to play, and that's making sure that I do everything I need to do so that they can do the best they can do.
There is something called split dosing. You know, the preparation involved in having a colonoscopy can be a little challenging. You don't want to be away from home, and often, and you might want to be the first appointment in the morning because you have to do a lot of things to purge your system. But can you talk a little bit, Dr. Sheikh, about why you might do what's called split dosing?
Yeah, I think it's basically for patient convenience factors. I think some patients feel that split dosing works well for them. Since I think I'm not I don't know much about how many patients prefer split dosing versus a...
And we should say split dosing means taking some of the laxative at night and then waiting again until the morning, right before your appointment.
Correct.
Okay. Do you have a comment on that?
The problem with split dosing is you have to get up pretty early in the morning, and a lot of folks are not too keen on that. I had a colonoscopy. I just went all the way with my 4 liters, and I had no problem with it.
Right.
I felt very cleansed.
Well, and I would say too, Patty, that in all of this and in everything that I've gone through and had to do, it's a matter of perspective. So it's like, yeah, it's inconvenient for a day and it's not really that much fun, but is it more important than my life? No, of course not. So, you know, yeah, you stay home and you stay in the bathroom for a while, and then you're fine, and then, you know, you let the doctors do what they do. And I think at that point, you know, everything's fine. You're not awake for it, or I chose not to be awake for it.
Right, and I think most people choose not to be awake. That certainly does provide perspective. We go to Janice, who is calling us from Erie. Go ahead, please, Janice.
Hi, I have a question as far as when is a good time to no longer have colonoscopies, risk versus benefit for an elderly person. I have an 84-year-old mentally challenged uncle who's never had any polyps, and I've just gotten his letter for his upcoming recommendations for his colonoscopy, and I know the prep is very difficult for him, so I'm wondering at what point does this become something that maybe you choose not to do on a reasonable basis?
Excellent question. Dr. Koo?
U.S. Preventative Task Force says not to bother after 75. They may change that as we live longer and longer and longer. I've had a couple of 92-year-old and 100-year-old patients with colon cancer. But I think in your situation, with an elderly parent, if at that age, it's probably not worthwhile having colonoscopy unless they have symptoms.
Yeah, and I think it really depends on the life expectancy also. So you have to look at the projected life expectancy of the patient. So if they're not likely to live another 10 years, so probably they may not benefit from the colonoscopy.
Tell us a little, Shireen.
Thank you very much.
Thank you for your call. How did this diagnosis change your life? You talked a moment ago about perspective, and I imagine that this has changed your perspective on a lot of things.
Sure. You know, I think one of the things that people ask me a lot is, like, when will you be back to normal? And I think the answer is, I mean, I'm not in any way going to be the person that I was before. It's not possible. So there's a new normal, maybe, but I think, you know, I think I lost a lot of people when I was young, so I never felt invincible by any means. But I think that having colon cancer certainly gives you perspective on what's important in life and who's important in your life. And, you know, a lot of the things that I think you define yourself by, like your job or whatever else, you don't have those things. You know, if you're gone and having surgery and you have to be gone for 2 months and you can't work and whatever else, it's like, well, what's left? You know, what are the things that are important to you and who are the people that are important to you? So I think that's probably been, you know, one of the big changes.
I think what scares a lot of young people when they hear colon cancer has to do with a couple of things. One, what does this mean to me in terms of having a family? Or what does this mean in terms of restrictions? You know, will I need a colostomy bag? Unfortunately, you didn't need that. But can you talk about age-appropriate treatment and what that means from where you're sitting?
Sure. So, you know, I read a lot. I always went into every appointment with lots of questions, pages of questions. But one of the things that I wasn't prepared for was the fact that chemotherapy could cause me to not be able to have kids. I didn't know that until I met with the group of doctors. And so that was probably the biggest blow. That was and has been the hardest thing for me to have to deal with. So I don't know that that's the case, you know. I'm not planning to have kids anytime soon necessarily, but it was certainly, I think that's one of the big things that was
you don't even think of.
No, you don't think of, because a lot of the research isn't talking about that, because most people who have colon cancer are above the age where they would be having kids anyway. So I think the infertility is one part of it. The potential for infertility, I don't know that that's the case.
And it's this, because of this combination of surgery and chemotherapy and radiation that could affect fertility. Dr. Sheikh, you had comments?
Right. Yeah, I think this issue is not just limited to colorectal cancer. It goes across the board.
Any kind of cancer.
For all young people in their reproductive age. And chemotherapy certainly is a major part related to infertility issue. So typically we do have fertility assessments prior to starting chemotherapy, such as for men, sperm banking, and for women, egg cryopreservation. So those techniques are available. In colorectal cancer, the chemotherapy drugs that are used commonly, such as oxaliplatin and 5-FU, they do have some effect on the ovaries in women and men, and there is about 15% chance of having some infertility issues. So I think the part of evaluation prior to starting chemotherapy should include a discussion regarding fertility issues down the line with your oncologist.
Anything to add, Dr. Koo?
And for men who are facing surgery in the low rectum, the big issue is impotence. We always have a discussion with them on that. If impotence is important to that man, and if they're under 50 or 60.
Okay. We go now to an email. We have someone who's emailed this question to us. I have a polyp on the end of my spine that the doctors say they can't operate on. What should my next step be, Dr. Koo?
It's not related to a colorectal issue. It's maybe a polyp, something that would be dealt with by a neurosurgeon or an orthopedic surgeon. But I don't believe that would be something that's, unless the polyp is in the bowel.
And a polyp can be benign.
Yes. A polyp just really means a projection of tissue, and that polyp can occur anywhere from my nose down to my toes.
Yeah, I agree. I think it depends what type of polyp or the location, and it may not be related to colorectal cancer exactly. Yeah.
Okay, we go now to Sharon, who is calling us from Cochranton. I'm not sure if I'm pronouncing that correctly, but please go ahead with your comment or question, Sharon. Is Sharon there?
Diverticulosis, and I had never had any symptoms from it before the colonoscopy, but I did afterwards, and I was worried about the air pressure that they use. Can that make those little pockets bigger? Because I'm kind of nervous about having another one done.
I think we missed the beginning of what you said. Did you say diverticulitis?
Diverticulosis, yeah.
Okay, I'm sorry. I'm sorry. So repeat your question, or did everyone catch that?
I understand,
Everyone got it? Okay,
I understand
Dr.
what
Chu?
she's trying to get at. Keep in mind, diverticulosis is a condition of aging related to our poor Western diet, low in fiber.
And explain what it is.
And it's just a weakening of the colon. Usually in the sigmoid colon, you get outpouchings. These are not pre-malignant. Certainly, you can have a blowout during a colonoscopy, but you would be acutely ill. You wouldn't be on the phone talking with us right now. You'd be in the emergency room if you had a true attack of diverticulitis. The problem with diverticulosis is that sometimes folks will also have diverticular spasm or just spasm of the bowel. So there's a great deal of overlap in these conditions. So if you get continued pain, you probably need to see your doctor or a gastroenterologist and talk about that. It doesn't mean that you have diverticulitis unless you have a high fever or pain so bad that you couldn't function.
Should she, in your opinion, be afraid to have a second colonoscopy because of this?
No, I don't believe so. I mean, diverticular disease affects a lot of us as we get older. So that's not a reason not to have a colonoscopy, because I think the concern here is screening and prevention of colon cancer, which can really get to you.
And actually, if you have diverticulitis, I understand that your risk for colon cancer is greater.
Not really.
Okay, and you would agree with that?
Yeah, I think it's not clear. It can cause inflammation and infections, but we don't know if it truly leads to cancer.
Okay, what are some things that do put you at greater risk? We talked about the fact that African Americans have a higher incidence. Actually, Eastern European Jews have a higher incidence of colorectal cancer as well. But what are other things that I'm thinking diabetes, for example. I'm reading that puts you at higher risk.
Right, certainly. So other factors like obesity, which leads to systemic inflammation, diabetes, which also contributes to inflammation. Those are well-known independent risk factors for actually any type of cancer, but certainly shown to be present in colorectal cancer as well. And they also impact their outcomes. People with diabetes or obesity are maybe less likely to do well with their treatments. But I think also things like inflammatory bowel disease, like Crohn's disease and ulcerative colitis, those are well-known risk factors for colon cancer. And then we have the genetic syndromes like Lynch syndrome or FAP, which are because of genetic mutations in the genes and that predispose patients to cancer. So knowing the family history is very important in assessing your risk.
Shireen.
Well, and so I just want to encourage people that even if you don't have any of those risk factors, which I didn't, except for being African American, you know, I've never smoked a day in my life. I don't drink. I don't eat red meat. You know, I exercised all the time. So with all of those things, so trying to do the preventative things and not having those behaviors is one thing, but if you have symptoms, you should still not ignore them and just think, well, I don't have any of those because I don't have a family history either.
How important is it to you, because I've read that it's important it's almost a distraction for people, especially someone like Shireen, who didn't fit any of the risk factors. You know, why? Well, okay, Dr. Sheikh.
Yeah, I just wanted to add a point here that African Americans actually, they have a maybe slightly different biology or even genetics of colorectal cancer. We are just beginning to appreciate some of it. They tend to have more distal or rectal cancer compared to proximal cancers. And some of their tumors are also mucinous or poorly differentiated signet ring features on the histology, which are also associated with bad outcomes and aggressive disease. So I think there is racial differences in the genetics and biology of the colorectal cancer as well, and that could explain some of the differences that we see. That is just one part of the, I think, bigger puzzle.
Okay, I want to go to Dave, who is calling us from Port Matilda. What's your comment or question, please, Dave?
Yes, I just wondered if there's any problem with getting a colonoscopy, particularly with the preparation part of it, you know, the purging and the liquid and all that, if you have or have had IBS.
Dr. Koo?
You mean irritable bowel syndrome?
Yeah.
Yeah, it shouldn't be a problem. You can have a bowel prep. It's okay.
And it won't trigger more problems. I can understand why someone would be concerned about that.
Interestingly enough, that purging, some people have said they feel better afterwards. In California, we pay for this service.
Right, as a health treatment.
Right.
Anything to add, Dr. Sheikh?
No, I think I would agree with Dr. Koh's assessment. I think patients usually are not very comfortable sometimes because they have to spend a lot of time in the bathroom. So, and people with irritable bowel syndrome, certainly they get easily, irritated in their bowels. But it should be okay. There's no contraindication to bowel preps in people with IBS.
Okay. And do you have another question for us, Dave?
No, that's good. Thanks.
Okay. Thank you for your call. You've gone through, Shireen, 12 chemotherapy treatments. Can you tell us a little bit about what that means and where you are in terms of living, going back to living?
So, yeah, I had chemotherapy for about 7 months. And right now, because of one of the medications in particular, I have neuropathy in my hands and feet, which is sort of a tingling makes it sound too nice, but it sounds like, you know, when you sit on your foot for too long and you have the pins and needles. So I have that all the time in my hands and feet. But aside from that, and aside from getting tired more often, I'm doing okay. And I think getting back to living is part of the process and part of afterwards, because you know, if you don't go back to kind of doing the things that you love to do, then there was no point in fighting in the first place. So for me, I had to really think about it and think, well, what am I putting up this whole fight for if I'm just going to be scared to, you know, leave the house or do anything? Yeah, so you fight to live so that you can live.
She mentioned some consequences that most people don't consider. We talked about the fertility consequences, but neuropathy is something that I think most people, it would never even occur to them that this is a possible consequence of cancer treatment. Can you tell us more about that, Dr. Koo?
Oh, I'll have to defer to Dr. Sheikh on that.
Yeah, I think, so there are survivorship issues, and we discussed the fertility. Neuropathy, unfortunately, is a big one because of the use of oxaliplatinum, which is one of the backbones of chemotherapy for GI tumors. So I think the part of the survivorship program is to focus on these issues and allow patients to live as healthy a life as possible. Unfortunately, neuropathy sometimes can be permanent. It does improve very gradually over time, but there might be residual neuropathy which is permanent. Usually when patients are undergoing chemotherapy, we are very careful not to push patients too hard so that they get very disabling neuropathies. So we grade the neuropathies from grade 1 to grade 4, 4 being having loss of function. So most of the medical oncologists would either reduce the strength of the chemotherapy or even stop it if it starts to go beyond grade 2. So I think while patients do have neuropathy issues, they're still able to maintain their daily function. So I think that's the key part here, that we need to preserve the function. There are other survivorship issues also, such as chronic diarrhea, which could be related to the radiation therapy and even chemotherapy. So we need to manage those as well. And I think also the role of family physicians is also important in conjunction with the medical oncologist in providing best supportive care as a survivor.
In your experience, and then I'm going to take a quick phone call, but in your experience with patients, what factors determine the outcome?
Yeah, so I think it starts from the right get-go. What type of tumor, the location of the tumor, the features on the pathology. So there are certain histologies which are associated with poor prognosis. So I think those factors are present as well. Stage of the disease is the most important, obviously. An early stage is curable, whereas advanced stage is not curable. So I think these features help us identify which patients are going to do well or not as good. And now we know that the genetic factors such as microsatellite instability, which is a defect of the DNA mismatch repair gene. So presence of those or absence of this feature also adds some more value in prognosticating the outcome of these patients.
Anything to add, Dr. Koo?
Probably just as Dr. Sheikh has mentioned, those are all critical things. The future is definitely basically getting a genetic roadmap of your tumor and then using that to maybe tailor the therapy. That's going to be in the future.
That's what I was wondering. What else is in the toolbox
That's in the
to
toolbox.
treat colon cancer, if not now, in the near future?
That will be like the studies that were just published this week are just going to improve the treatment results.
All right. We go to Mary, who's calling us from Warren. You're on the air, Mary.
Yes, Mary Schmader calling from Warren, Pennsylvania. And I had some good advice for your audience there. I never had a colonoscopy until I was 66. And I had a large polyp taken out, huge. He had to go in twice to take it out, my doctor here. So I came home, and 3 years later I went back, and I had more polyps, non-cancerous. So I'm very lucky. I go back, I'm 70 now, and I go back in 3 years. Well, it'll be 2 years after this year.
And so are you wishing you had gone at, are you wishing, Mary, that you had gone in at 50?
Yes, I do. Several doctors said, let's do a colonoscopy. I kept putting it off. So I'm very blessed so far that it wasn't cancer.
Well, we're glad to hear that, and thank you very much, Mary, for your phone call.
You're welcome. Thank you.
Thank you. The interesting thing about what she's saying is, you know, when you go in for the colonoscopy, if there is a polyp, they can remove it right there and then.
In most cases.
In most cases. Why wouldn't you be able to remove it, Dr. Koo?
If the polyp is particularly large or particularly flat, or in a particularly thin-walled area of the colon, they may not be able to safely remove it. So that patient may end up coming to surgery to have the so-called resection or removing part of your bowel.
Okay. We go to Donna, who's calling us from Johnstown. What's your question or comment, Donna?
I have a problem about the PrEP. I've never had this done, and I cannot drink a lot. 4 glasses of water is too much for me. How do I go about this? I had an aunt who went through this, and she was throwing up towards the end of it, and I don't want to do that. So what can you tell me about a better PrEP?
Unfortunately, there is no better PrEP than this. We had another PrEP that was taken off the market because it was causing deaths and renal failure or kidney failure. So this stuff really, if you can't do a lot, you can do it, talk to your doctor, negotiate. You could do it over several days and stay on a fairly clear liquid diet and just take it very slowly.
And
How much is needed to drink?
A gallon.
A gallon.
And in some cases, you can get along. There are some PrEPs where you only have to do half a gallon, which is 2 liters. Yeah.
What's the name of that?
You'll have to talk to your gastroenterologist. They'll have all that stuff for you.
Okay.
Yeah.
Shireen wanted to add something?
Yeah, I just was going to say that I know that different people had different preps. Different doctors will allow different kinds of prep, because I know a friend of mine had something I can't remember the name of, and mine was a mixture of Miralax and Gatorade and some other things in the process. So I think Dr. Ku's right. You should definitely talk to your GI doctor about it, because they might have different options and different ways. I mean, there were things that people were telling me about that I'd never heard of, even though I've had 2 colonoscopies.
There are some preps that use a chemical, and some of them may, if you're an older patient who has borderline kidney function, it may affect you. So you really, as Shireen says, do talk to your doctor.
All right. Thank you for your phone call. What about, Dr. Ku, how important are medications that someone might be on prior to having a colonoscopy? I'm thinking of something like aspirin or prescription drugs.
The drugs that we would be concerned with are exactly what you said: aspirin or blood thinners such as warfarin or Coumadin. In the case of aspirin, I don't have the patients generally stop that unless I'm concerned about bleeding in that particular patient. But for warfarin or those blood thinners that you take by mouth, we would have them stop that about 4 or 5 days before.
There's a website, Shireen, called Stupid Cancer, and it's really directed for this growing number of young people who are experiencing all different kinds of cancer. Tell us a little bit about it, because it seems like such an important resource for young people.
Yeah, Stupid Cancer is one of them. There's also, I'm part of a Facebook group specifically for young people with colon cancer, and that's been really helpful for me, because it does feel isolating. If you are in, any treatment area, doctor's office, you're going to most likely be the youngest person in the room all the time. But it's not the case. It's just that we're all spread out. And so when we have a network now where we can talk to each other and give support and talk about some of the issues that only affect young people. And so that virtual environment has been really good. Stupid Cancer is one of those organizations. There are quite a few of them. And then there are the larger organizations like the Colon Cancer Alliance that has that specifically has, specific programs that deal with young people. So
I think you met someone named Gloria Burgess through some of these support groups. She was a young, really hardworking 28-year-old attorney when she was diagnosed with stage 4 colon cancer. And one of the most amazing, astounding things to me is that in the process of her telling her own story, 4 acquaintances from college and even earlier reached out, told Gloria how they were feeling. Each went and had a colonoscopy, and all 4 came back with positive colon cancer results.
Yeah, and I actually never met Gloria. I learned about her when I was diagnosed, because she went to Duke like I went to Duke, and so we had a lot of mutual friends, and unfortunately I didn't get to meet her, and so I was very devastated by her passing. But she did what I think a lot of us are doing, which is just spreading the word as much as possible so that no one else has to go through what we've been through. And she was really focused on a cure, which I know she had a very close relationship with her doctor, just trying to get the word out and get people to pay attention to symptoms
and to increase funding for colon cancer,
Sure.
which I think is an enormous need. We go now to Ed, who's calling us from Milesburg. You're on the air, Ed.
Hi, Patty. You're doing a great job.
Thank you.
There's a lot that I could say, but I'll try to focus on one issue. I'm a 10-year survivor of colorectal surgery.
Good for you.
It was rectal surgery. I was overdosed on chemo, and it's had some pretty harsh effects, and I'm not happy about it. But it seems to me that if we're not going to screen people under 50, the folks who are under 50, and I've lost several of them, who had stage 4 cancer, and one of them was dead before she was 40 and left a 9-year-old daughter. Tragic. She was one of the most helpful people to me when I was going through it. But a couple of the symptoms, I had hemorrhoids all my life, And so when I got stool that was sort of misshapen or had a flat side on it, I just attributed it to that. I went to see a doctor who finally did the digital rectal exam, and he said, yeah, you have hemorrhoids like we've been writing down, like he had been writing down, and an enlarged prostate, but he had run his finger over a tumor that was 3 by 4 centimeters and had been in there for 10 years and misdiagnosed it. So I guess what I'm saying is, for people who are having any signs at all, and this misshapen stool is one of them that people probably are not going to mention, that is a signal. And having hemorrhoids doesn't eliminate the possibility that you also have cancer.
Thank you. Thank you. That's a really helpful phone call. Dr. Sheikh, what can you add to that?
Yeah, I think to the first point about the chemotherapy overdosing, so we now know that everybody metabolizes drugs differently, and I think that's related to the genetic factors also. There are now newer tests available on the market in which we can dose your chemotherapy based on the pharmacokinetics, how the drug is metabolized. And I've been part of one such initiative where we have been dosing the 5-FU based on their actual levels in the blood, as opposed to calculating based on your body size and height.
So should patients be demanding blood tests? And I know that's part of a routine, part of cancer treatment, but...
Right, yeah, I think, so it depends. It's not standard of care as yet, but I think there's a lot of promising data on such testing. So hopefully the insurances will start covering it, so we can offer it to every patient who's going to be on 6 months of chemotherapy. But at this time, we still, it has to be on a case-by-case basis. But it's an option, and I think you can discuss it with your medical oncologist.
Our caller also mentioned some symptoms that we may not necessarily recognize as possible symptoms of colon cancer. He mentioned what his bowel movement looked like, and actually that's something to consider.
Right, yeah, I think we have to keep a low threshold for suspecting colorectal cancers, and any symptoms suggestive of rectal bleeding, which is persistent, abdominal pain, which is also constant and not going away, should be further looked at by a CT scan or even referred to a gastroenterologist for a colonoscopy examination.
Okay. Anything to add, Dr. Koo?
I think the most common thing I hear is the attribution of your symptoms to hemorrhoids. Keep in mind, everybody has hemorrhoids. We're all sitting on our hemorrhoids right now. So don't blame your hemorrhoids for it. If you've got something wrong, go get it checked.
Okay, good advice.
Yeah, and I just want to say that a lot of the young people that I've talked to, I asked them, one of the things they wanted to make sure I talked about tonight, and a lot of them were misdiagnosed or with IBS. And so
irritable bowel syndrome.
Right, for a long time. That wasn't the case with me, but I know that happens sometimes. And, if you know that something's still wrong, to just keep pushing for...
Anemia and hemorrhoids are other not that you don't have hemorrhoids, but missing the bigger diagnosis. We go real quickly to Tony from Erie. You're on the air, Tony.
Yeah, I've recently read some articles about virtual colonoscopies, and I'd like to get an opinion of one of the doctors or both of them as to what they feel about virtual colonoscopies, and our insurance is covering that. They could address that.
Dr. Koo? First, explain what that is.
Virtual colonoscopy is basically a CAT scan of your abdomen where they inflate air in your colon, and basically they use supercomputers and they can fly through your colon looking for lesions. The problem with virtual colonoscopy is it's not terrifically accurate. It's not as accurate as a regular colonoscopy. Of course, there's no risk to a virtual colonoscopy except for the mild radiation exposure. But the problem is that most insurance companies will not cover this. They may cover it if, let's say, we couldn't complete the colonoscopy for whatever reason, and sometimes that occurs. You could get a virtual colonoscopy perhaps covered in that situation.
But my guess is, it sounds like you're saying, get the real colonoscopy.
In most cases, yes.
All right, thank you for your call, Tony. I don't think we have time to take another phone call, so I just want to go around the horn here and begin with you, Dr. Sheikh. What's your take-home message?
So I think we have made significant progress in colorectal cancer, both in diagnosis and treatment. However, we are seeing a new trend of young onset colorectal cancer, which has a different biology maybe and genetics. And I think we need to pay more attention to it, both as physicians and as patients, getting more education and being more aware of these symptoms of colorectal cancer, and also having a low suspicion on the physician side of diagnosing these
Don't think of it last.
Correct.
Okay. Shireen?
I think my take-home message is for people to not be embarrassed and not be scared, and to trust your gut, because you know your body better than anyone else, any doctor, any nurse, anyone else, and you know if something's wrong. And if you think something's wrong, it's probably, I mean, it's not that it's necessarily cancer, but it could be something that could be easily fixed. So just trust your instincts and demand what you feel like you need to get.
And can you tell us where you go from here? You've gone through surgery and from chemotherapy, and what's next?
I have lots and lots of tests all the time. I have a CT scan coming up, that full body scan to make sure that everything's okay. And I'll just, I'll have to get a colonoscopy probably every year for a few years, and then just keep getting tested.
All right, continue to do well. Dr. Q.
Keeping in mind that Shireen's situation is very, very unique, the bottom line is the only risk factor I consider is age. If you're over 50, go get screened. I don't care how you get your screening. If you're just going to test your stool, you're going to get your colonoscopy. Any test is better than doing no test.
Okay, thank you all so much for joining us this evening. Our guests tonight are Dr. Hassan Sheikh, a staff oncologist at the Cancer Care Partnership, which is a joint venture of Mount Nittany Health and Penn State Hershey Cancer Institute, Dr. Robert Koo, a colorectal surgeon for Geisinger Health System, and Shireen Stanford, currently in recovery after surgery and chemotherapy. And for resources on tonight's topic, visit our website, wpsu.org/Conversations Live. We hope you'll join us on Thursday, April 24th, when we'll be continuing our discussion on Lyme disease with a focus on treating humans. Thank you all for watching and listening. I'm Patty Satalia. For all of us here at WPSU, have a good night.